Hello, everyone, and welcome to the sixth and final session of the Inaugural Completed Life Conference. My name is Sarah Kiskadden-Bechtel, and I am delighted and honored to welcome you today as your host and as the Program Director of the Completed Life Initiative. Today's session explores and examines completing life by voluntarily stopping eating and drinking, also known by the acronym VSED, VSED. And I am honored to welcome renowned experts on VSED, David Gruenwald and Thaddeus Pope, for a lively discussion on the legal, ethical, and clinical considerations of VSED. Some background on Dr. David Gruenwald. He is the medical director of the palliative care and hospice service at VA Puget Sound Healthcare System, and the associate director of the Palliative Medicine Fellowship and associate professor of medicine in the Division of Gerontology and Geriatric Medicine. His varied clinical interests in patient care near the end of life include the management of symptoms, especially difficult pain management problems, palliative treatments of last resort, including palliative sedation and voluntarily stopping eating and drinking, and conducting goals of care conversations, including key communication skills. Some background on Thaddeus Pope. He is an expert on medical law and clinical ethics and is the director of the Health Law Institute at Mitchell Hamlin School of Law in St. Paul, Minnesota. Professor Pope works to calibrate the balance between individual liberty and public health in the end-of-life medical treatment context. He maintains a special focus on patient rights and healthcare decision-making. He co-authors the definitive treatise, The Right to Die, The Law of End-of-Life Decision-Making, and he runs the Medical Futility blog. Finally, the president of the Completed Life Initiative, Jason Smith, will be joining us today to conclude the session in the last 15 minutes of the second hour. And we're delighted to have Jason, Thaddeus, and David here today. And I'd like to now begin the conversation with Thaddeus. So over to you, Thaddeus.
Thank you, Sarah. So as Sarah said, right, this is the sixth of 6 sessions in the Completed Life Initiative Conference. So today, David and I are building on a terrific foundation. So we're going to take just a minute to stop and assess what have we learned so far, right? We've seen a few things. We've seen, particularly from session 3, that there's no ethical consensus on how to distinguish morally and legally acceptable means of hastening death from morally and legally unacceptable means or acts that hasten death, right? No consensus about how to distinguish, for example, withholding and withdrawing life-sustaining treatment from MAID or VSED. We've seen that inequities in society and in our healthcare system have created disparities in socioeconomically disadvantaged and marginalized communities with respect to health status, with respect to access to healthcare. And that's left a legacy of mistrust in these communities, concerns that they have about the motives of clinicians that are counseling them about alternatives at the end of life. We saw in the last session that discerning what the best end-of-life care looks like has to start with the individual's narrative, their experience of care and values around care. The patient and the clinician have to work together to a shared understanding of the route that best aligns with that narrative, right? So before discussing specific means like VSED or MAID about hastening death, healthcare professionals have to understand the person's underlying concerns. They have to consider ways to mitigate causes of existential or physical suffering and ensure that patients have carefully considered the benefits and burdens of all the available alternatives. And unfortunately, we've also heard, especially in session 2, that clinicians often don't conduct skilled conversations about a patient's values, preferences, and options. So there's a lot of over-treatment, a lot of unwanted treatment at the end of life. So David and I today are going to talk about just one means, VSED, VSED, as Sarah mentioned, voluntarily stopping eating and drinking. And this has come up in several prior sessions, but we're going to take a deeper dive today. VSED is a deliberate, intentional decision by a patient who's physically capable of taking food and fluid by mouth, but makes a deliberate decision to stop the intake of all food and fluid by mouth with the intent, with the objective of hastening her death. And that will usually follow in 10 to 14 days. Typically, a patient does VSED in the setting of unacceptable or prolonged dying or refractory suffering. But unlike MAID, which we talked about a bit, VSED is much more widely accessible, right? MAID is only available in a small handful of jurisdictions in the United States, only a small handful of jurisdictions in the entire world. VSED is pretty much available everywhere in the United States, everywhere in Australia, everywhere in most jurisdictions, right? And we saw that in Australia and the United States, at least, maybe not Canada, VSED or MAID is only available to patients with terminal illness. In contrast, VSED is available for patients with degenerative disease in advance of terminal illness. So here's the plan. We're going to go in 4 stages. First, David's going to present the case. Second, David and I are going to talk about what lessons we can learn from this case and others who've had different experiences and different outcomes. We'll continue the conversation, third, by digging into some aspects of VSED that haven't been touched upon as deeply in prior sessions. And finally, we're going to open things up for quite a bit of participant Q&A. But before David presents this case, before we get started, we want to hear from you. So if we could bring up a poll question, we want to assess how familiar you are with VSED. So you should be seeing the first poll. And people are starting to respond. And basically, it's just a Likert scale. Are you not at all familiar, a little bit familiar, somewhat familiar with VSED, moderately familiar with VSED, or very, very extremely familiar with VSED? And we'll share these results in just a minute. It looks like over 100 people have already responded. We'll wait half a minute or so to give people a chance to click in your answers. So it looks like the voting has slowed down a bit. So maybe we can share this now. So you should now be able to see these results. And actually, this is maybe, we'll see what David says, maybe a little bit surprising that there's a fair number of people who voted on the high end here that are moderately or extremely familiar with VSED. But of course, there's also just as many people who at the bottom end as well. So thanks for doing that.
Great.
We have one.
Thank you.
Yeah. Did you have a comment on the poll results, David?
No, I really don't. Maybe this is a self-selected audience, already enriched for familiarity.
Right. But we have one more poll question for you. So this one's a little bit different. This one, the first one that you just answered was, how familiar are you with VSED? Now what we want to ask in the second poll question is, have you actually participated in VSED? So we can share that poll Okay, that's been sent. And so the question is either as a family member, you had someone in your family who explored VSED or actually underwent VSED, or as a clinician, you supervised a patient undergoing VSED.
So these results appear to stand in marked contrast that although familiarity is common in the survey group, personal participation is not so common and much less common as a clinician.
Right. So so let's share. I think there's over 100 people who voted here. So maybe we can share these. Okay, good. Yeah, that's right. So 73%, 72% have not participated either as a family member or as a clinician. Although it is interesting that 20% of the participants have participated, and as David notes, almost no although we don't know what the baseline number of clinicians on the call is.
Correct.
Good. So we'll reference back to this a little bit later. Thank you. This helps us get a sense of who we have in today's conversation. So I'll turn it over to David to share his case.
Yeah, thank you, Thaddeus. So I'm going to
David,
present. Yes.
One moment. I'm sorry to quickly just jump in and let everyone know for the continuing education credits, the code is VSED, all caps. We'll put it in the chat as well, but a second code will be coming at the top of the hour. Thanks so much. Over to you, David.
Thank you. So I'm going to present a case that's very close to me, close to my heart, because it's the case of my mother. And I think you may be seeing a photograph of a book that she authored, one of two memoirs that she wrote in her 80s. She is a very dynamic person, and she was in healthcare for much of her professional life. She, as a nurse, managed an emergency department and pioneered the development of the consulting nurse role, which we take for granted now. And I remember visiting her in her office and seeing this Rolodex, kind of the primitive origins of the consulting nurse role, which then morphed into a book and then expansion of the role to other healthcare systems over time. And then she retired, and it was a so-called retirement. She began a new chapter of her life as an author, authoring this memoir that you will see shown on the screen, and another one. And she toured widely to locations as far as Japan to speak on her experiences in the so-called internment camps in World War II, where the family was incarcerated. So to her attitudes about dying and death, she has been preparing for her death for at least 3 decades. And it was just kind of a part of the family woodwork that she would say things like, you know, when it's my time, I just want to go. And she'd kind of joke around about maybe you can just, kind of like the Eskimos do, put me on an ice floe and let me float away. But more than that, she planned. She bought long-term care insurance when that was not a common thing to do. And she completed her advance directive and made it as explicit as possible about her intentions. She really wanted to prepare us, her adult children, and also to get everything in order. And that worked great until frailty and declining cognition got in the way. So by the end of her 80s, she was aware that she was unable to remember things so well, and this caused her a lot of distress. So her father died of Alzheimer's disease at 93 years old, and there was a long period of time of increasing dependence on the family to meet his care needs. And so she was aware of the option to stop eating and drinking towards the end of her life. And this is something that I was unfamiliar with in my professional life. In other words, I didn't see any literature on the topic. There was no discussion in professional circles. Even though I'm a palliative medicine doctor, at this time there was no discussion about VSED. So she wanted to control her fate, and she thought about this as an option to maintain control while still able. And because I'm a physician and because of the nature of our relationship, she confided mainly in me. And this caused me to be a bit distressed myself. I wondered, what is this going to involve for me personally and professionally? She was living in an assisted living setting by then, and it was hard for me to imagine that she was going to be supported by the facility in this intention. So would we bring her to one of our homes for care during VSED? And she's well known in this community, and I'm well known, and eventually word would get out, and I was concerned, frankly, that would I be seen as conspiring in an unethical suicide plan if I participated in this? How would this be perceived? So ultimately, I had to kind of take this process out of the closet, involve my brother and sister in the conversation, and also to involve her family physician, who is also my physician, in the conversation. She didn't actually have a diagnosis, and it turned out she was not demented at that time. She had mild cognitive impairment with memory impairment. So that was important information. And in the conversation with the family, we talked a lot about why she wanted to hasten her death. And it was around the notion that she worried about burdening the three of us adult children. And unpacking that more, she was concerned about, although she didn't quite put it like this, she seemed to be concerned about leaving us a financial legacy and not saddling us with her increasing care needs, physical care needs, as well as just the emotional burden as she saw it. So that was important information for us. And our response was, Mom, you have prepared better than anybody I know for your eventual death. It's not a burden to us. And in fact, it's our privilege to walk this journey with you. And we're okay with that. And you are a blessing to us. And what's more, you are still contributing to your community. You've left a very rich legacy of friendships that are ongoing. You have your life story that you've recorded for us and continues to resonate with people in the larger sphere of influence that you have. So enjoy your life. Enjoy your life. You're living a good life now, and at such time as you need more help, we will help you set that up, and we'll be your advocate. So she did adapt to this, and ultimately, somewhat grudgingly, she accepted this idea of staying alive and eventually needing more and more assistance. She is no longer driven and dynamic in the way she once was. But she's happy. She's content to watch the world go by and to be taken care of when she needs it. And of course, this story is not yet fully written. It's not over yet. But in talking about this with her, I obtained her permission to tell this story, and she blossomed and started talking to me just a couple of weeks ago about the love and trust and respect that we have for each other, and how that makes it possible for us to talk about things that are difficult and to acknowledge to each other the challenges of facing things like end of life. So that's our story.
So, David, what do you think are lessons that others can draw from this story?
Well, a couple that I'd like to highlight. Just how important it was to unpack her narrative and really for us to understand why she wanted to do this, and to talk about this notion of burden that troubled her so deeply, and to really share that story with all of us, and to kind of let her off the hook and to say, we are okay, we're going to be fine, and we want you to reap the benefits that are still accruing to you of all the planning and work that you have done over the years. So please allow us to do that. So that was this narrative being unpacked with each other. Another point is that I have seen situations in other patients, other people who are facing debilitation and end of life, especially around nursing home placement, where maybe people go in with the thought, I never would want to live like that. But when faced with the reality of change that is no longer avoidable, some, though not everyone, change their minds and to say, well, this maybe wasn't as bad as I thought it would be, or it's difficult, but I can accept this. So there's this phenomenon in the literature called response shift. And that happened in my mother's case, and it may happen for others, but not everyone. So I imagine you have some thoughts as well about the case, Thaddeus.
Yeah, I mean, thanks for sharing the story. I mean, there's a lot of observations, but let me just focus on one, right? It does seem that your mother was lucky to have more options than most, right? There's a lot of people who are facing prolonged debilitation at the end of life and may have had a very different experience, a different outcome, right? There's a lot of people, including probably many people, I see questions in the chat already, that want to avoid what they consider to be poor quality life with advanced dementia. Yet many people experience just that type of life that they want to avoid. And so the path taken by your mother isn't really available to many people who lack the same family and financial resources. Because as you noted, she had access to excellent care. You're a physician who, with expertise in both geriatrics and palliative medicine, you were able to advocate for her effectively. And a lot of people just aren't privileged in those same ways. And so we do have to consider how to overcome those kinds of disparities in access to healthcare resources. So people with fewer financial, family, and other resources from you and your mother can have the same sense of completion at the end of life that they think is right for them.
Yes.
But let's dig into some aspects of VSED that weren't really discussed as much in the prior sessions. We heard a few times that determination is required to follow through with VSED. And that sort of implies that it can be pretty tough. So let's talk about the experience of VSED. Is it, in fact, comfortable?
It probably depends on the person's underlying functional state, their nutrition and hydration status going into it. It's notable that as we get older, our thirst mechanism tends to decline. And as we get sicker, we're probably less bothered in a way by hunger and thirst than if we are physiologically more robust. And so a younger person trying to do this who is relatively healthy physiologically is probably going to have a much harder time with VSED than someone who is quite frail and whose kidneys don't hang on to sodium and water the way a younger person's kidneys would. So that baseline physiology makes a lot of difference. So in the actual experience of VSED, the most common symptoms that people encounter are dry mouth and thirst. And for those symptoms, frequent mouth care and the use of saliva substitutes, lip balm, and the like are really important. And it's imperative for the person and their caregiver during VSED to know that even sips of water, just a little bit of water, will keep the kidneys open and can prolong this 10 to 14 day period by quite a bit, even indefinitely if enough water is taken in. So it prolongs the process. Now, by contrast, the hunger is usually transient and well tolerated. And there's some anecdotal evidence that if a person stops the food intake a week or more in advance, it may make the thirst experience easier to tolerate. So that's kind of the initial period of VSED. And then as you move into kind of the middle period, when this has been going on for a few days, it's common for people to develop somnolence and even delirium, that phenomenon of having difficulty paying attention to what's going on. Some confusion may be present, some disorientation. And once in a while, agitation can kind of take on a life of its own. So it's really important to have a plan for that in advance if that does happen and agitated delirium develops. So will we use sedating medicines to control that symptom? And then in the final phases, it's inevitable that people are going to become weaker and ultimately completely dependent for all daily activities, including turning and skincare. So there has to be a good plan in place for caregiver support to manage those kinds of situations. So maybe it's good for us to shift a little bit to think a bit more about who it is that considers VSED and actually follows through. And maybe Thaddeus, if you have some comments on that.
Yeah, we don't know as much as we would like. It hasn't been studied as extensively as MAID, where we have Department of Health reports being published every single year in all 10 of the US states and Canada and everywhere else. But we do have some good data from the Netherlands, data from Oregon, and then some more recent data from Switzerland. And what they show is that people who die by VSED are older than 80, which is significantly older than MAID, which is 74 years old average, functionally dependent upon other people for care, have a short life expectancy, and more likely to be affected by neurological disorders than cancer, which is the dominant, by far, diagnosis for MAID. And the motivations, why do they pursue VSED? They report they're ready to die, that continuing to live is pointless, their quality of life is poor, they want to die at home, and they want to control the circumstances of their death. And at least in the European countries, so there are professional association guidelines in the Netherlands, in Switzerland, and in some of the other European countries that say a good candidate for VSED should be somebody with a terminal illness or at least a serious debilitating illness, have intolerable suffering despite excellent support in palliative care. They have decision-making capacity. They're informed of the risks, benefits, and alternatives to VSED. And so they're making a voluntary choice, free of coercion and duress. They have adequate caregiver support. And the clinicians make sure that this is consistent with their long-standing values. And I know you're going to emphasize this, it's often said that VSED is patient-directed because you could just stop drinking. I mean, you don't really need a doctor to give you anything. That seems to be within patient control. but your recitation of the various symptoms of dry mouth and delirium and so forth, I think illustrates the fact that while technically or theoretically it could be completely patient-directed, you really, really need clinician support. And all the guidelines say that that is highly encouraged, both for counseling and guidance to make sure that this is even the right choice for you, but definitely once it begins to manage the physical symptoms and also the psychosocial support, not just for the family, not only for the patient, but also for the patient's family. So maybe you could pick up on that and maybe talk about what are the actual steps that, from the clinician's perspective, that you would go to if a patient says, "Hey, Dr. Gruenwald, I saw this webinar on October 8th, and I'm thinking about doing this." Well, how would you proceed to respond to that kind of question?
Thank you, Thaddeus. It's good to have a checklist as a clinician, and I think that checklist flows from some of the comments that you've already highlighted. And the place to begin as a clinician is to really set the stage with the narrative. And as a palliative medicine physician, understanding the patient's story is absolutely crucial. So instead of responding, if a patient comes in saying, "Doctor, will you help me die?" Instead of responding directly to the question, I might say something like, "I'm going to answer your question, but before I do, it really helps me to understand why you're asking me this question today." So that sets the stage for a conversation around why, just as with my mother. So is it that the person wants my help today to get started with the process, or maybe they are theoretically interested in VSED at some time in the future, or maybe they want to start with the planning process and just kind of have something in their back pocket just in case. And then we need to open the door even wider to understand what are the causes and origins of suffering for you as a person. Is it pain in the present moment or worry about pain? Is it a sense of not wanting to burden my family? Is it I've been an active person all of my life and now I have a spinal cord injury or ALS and I can no longer do those things that give my life purpose and meaning? And so why am I still alive? Maybe it's an existential or spiritual distress that the person is feeling. So understanding the origins of suffering is crucial before we get into any conversation about VSED per se. And just having that conversation in itself can allay many of the concerns that some people have. And I can think of the very first case that I had where somebody asked me to hasten their death. And this was a person who I had a conversation around stopping eating and drinking. If you decide you want to do that, then we'll support you in every way we can to make this a comfortable and dignified experience. And this person did better after that conversation and never actually so-called pulled the trigger on stopping eating and drinking. So suffering reduced after this person knew there was the option, is the point I want to make. So going through the checklist, we need to assess decision-making capacity. So this is something that a person needs to be able to evaluate options and to be fully informed about risks and benefits and alternatives to VSED. We want to evaluate for medical contraindications such as untreated depression that could affect decision-making, for decision-making capacity problems, including cognitive impairment, and psychosis can interfere with decision-making. And we may need to bring in other members of an interdisciplinary team, maybe a psychologist, perhaps a social worker if there are a lot of socioeconomic concerns leading to this desire to hasten death, or chaplain support, or spiritual and faith leaders for spiritual distress. We must have an advance directive in place. Surrogate decision maker needs to be established who hopefully could advocate for the person. And this notion of advocacy is really going to come up again and again. A do not resuscitate order must be in place, and a plan for robust caregiver support before VSED is started. So now we're moving into more of the specifics of VSED management, which can only happen after these other steps have already occurred. A symptom management plan I alluded to a little bit earlier, including the dry mouth and the thirst and agitated delirium, and how questions about requests for restarting food and fluids after VSED has begun, how will that be managed, especially when the person is no longer able to make a capacitated decision? So that has to be thought through in advance. And also having hospice services in place can really help with the symptom management and the overall support that's available. So why don't we transition from comfort management and kind of the checklist into talking about ethical issues associated with VSED. You want to take that one away?
Sure. A lot of ink has been spilled in the VSED debate about whether VSED is suicide or whether VSED is not suicide. And unfortunately, labels don't get us very far. Definitions don't get us very far. I mean, VSED is an intentional act with the objective and the result of the patient's death. But so is stopping dialysis. So is signing a DNR order or a post. None of that is considered suicide. So I think what this reveals is that suicide is really now often used as a normative term, not a descriptive term, right? We use it to describe deaths that we think are regrettable, deaths that should have been prevented. So in short, I mean, at this point, suicide is a very value-laden term, a negative value-laden term. And we generally, as a society, since we literally in our state statute say that MAID is not suicide, withholding life-sustaining treatment is not suicide, withdrawing life-sustaining treatment is not suicide, that it doesn't apply. The term suicide doesn't apply when the patient is already dying and makes a choice in the face of imminent death. Right? Suicidal people don't want to live anymore. People requesting VSED generally do want to live. It's just that they typically have an illness that's already killing them. And so the option to live isn't really available. All they can do at this point is control this precise timing and manner of the death. And it is worth noting, if you look at the professional associations, the codes of ethics for nurses, for long-term care, and for others, VSED is generally accepted across in those codes of ethics. And that's not surprising because it fits very, very well with broader ethical principles of healthcare decision-making, which is we can all refuse any intervention into our body, even if the intervention is beneficial, even if it's life-saving, right? Indeed, if you actually tried to force feed somebody who didn't want to be fed, or you took some invasive measure to do a feeding tube against their will, that would be considered a battery against the person, both a tort and a crime. And so we really have no choice but to honor the patient's wish to VSED. As long as you said, we've confirmed that it's a truly voluntary and informed decision.
Yes, so some legal terms are coming into the conversation. So maybe you could talk a little bit about the legal status of VSED. And I have to admit, I was concerned about that in my mother's case, so I was unclear.
Right. And in fact, it's a good observation, because oftentimes the legal analysis and the ethical analysis overlap a little bit and mutually inform each other. What we don't have with VSED, and this is probably why you were a little bit uncertain with your mother's case, and others are as well, is because we don't have black letter law. explicitly telling families, explicitly telling clinicians that they may VSED or that they may honor a VSED decision. We have that kind of clarity. We have that kind of certainty for MAID because everything's laid out in the Washington Death with Dignity Act. And we don't have a VSED Act. That said, dozens of courts in the United States, courts in Australia, courts in Canada, and elsewhere have provided guidance saying patients have a right to VSED, and clinicians may and should honor those requests. And again, not surprising because the underlying rule is patients can refuse any intervention, even food and fluid by mouth. People are sometimes concerned that this constitutes the crime of assisted suicide, which remains a crime even in Washington, Oregon, California, and MAID states. But the law clearly distinguishes between active measures, introducing a lethal substance like you would with MAID, versus passive acts of just allowing natural death, like VSED. And in any case, those statutes almost always carve out the situation where the physician's role is merely palliative. They're not the ones causing the death. That's under the patient's control. They're just alleviating symptoms for the VSED that the patient has initiated. And that's exempted from the scope of prohibition. And finally, some people are concerned about neglect. Every state has rules about abuse or neglect of vulnerable adults. But those laws are also very, very clear that the patient may waive those protections if she wants to, right? So again, if the patient is making a voluntary and informed decision to VSED, she is thereby waiving her right to be protected from dehydration, and therefore dehydration in that where it's wanted and desired by the patient wouldn't be considered neglect.
So back in 2014, I felt like I was the only one dealing with this. I mean, there was no conversation going on in my professional circles, and it left me kind of wondering how common this is. What do we know about that?
It seems to be, and this is why we're doing this today, right? It's because we're trying to cast a spotlight onto this because it's widely available, but not well understood. It seems to be perhaps more common in some European countries. So we have published data from the Netherlands and from Switzerland where VSED leads to, depending on which studies you're looking at, 0.5% of all deaths, up to 2% of all deaths in those countries. And even today, right, 2014 is one thing, but even not right now in late 2020, VSED appears to be less common in the United States than in Switzerland and the Netherlands. Why is that? Probably because clinicians are relatively unfamiliar with it. There isn't a lot in the literature. And to the extent there is stuff in the literature that only has been published in the last couple years by you and others. And because of the lack of what we call black letter law, explicitly saying this is permissible, clinicians are still a little bit uncertain about its ethical and legal status. So, but on a practical level, even if the law were clearer, how is it perceived in the hospice world?
Overall, what we know, there's some earlier data from Oregon, and this came from a survey of hospice nurses. And in this survey group, the nurses were more supportive of VSED than they were of physician-assisted dying, or MAID, as it's also known. And there were over 100 nurses in this survey, and only 3 of them felt that allowing VSED by a hospice patient was unethical. And some of them would consider it for themselves as well. But having said that, there are barriers in some cases, and the mission of hospice is generally perceived to promote comfort, and neither to artificially prolong nor artificially shorten the dying process. So there may be some ethical concerns on the part of some hospice staff to participation in VSED. And VSED, it should be noted, is not a comfort promotion strategy. If what you want is symptom control, there are other ways to achieve that. But the process of VSED can be uncomfortable due to the thirst and other symptoms that can develop. So that may lead to some concern from hospices. The second thing is that unless you are deemed to be quote unquote terminally ill, which is artificially defined as 6 months or less as an estimated prognosis to live, then there may be a delay in enrolling people who start VSED for people who are not within that estimated window. So for people with serious chronic degenerative illnesses, hospices may say, well, we'll enroll you, but only after you've been doing VSED for a few days and demonstrated your commitment to the process. So figuring that out in advance with whatever hospice agency works in your area is a good idea to kind of get on the same page first.
So that's hospice. And I suppose what if I ask you now about long-term care and the willingness of long-term care to participate, that you're going to give us a different answer.
Well, there will also be some variation in willingness to participate, and there are some particular structural reasons, I think, why this could be problematic. But there have been reports of residents of long-term care facilities being expelled from their placements after disclosing their intent to VSED. So it's good to kind of figure that out in advance before you enter a long-term care facility, what the philosophy and approach is likely to be. And it's totally understandable from the perspective of an administrator in a long-term care setting. Their core mission is to protect the vulnerable individual and to meet the needs of people who need assistance. And there may be concerns about accusations of neglect or that we would be mandated to report suicidal intent for people who express a desire to VSED. So resident safety is understandably a priority. However, what we also know is that person-centered care is considered best practice. And so understanding the person's priorities and their preferences for care based on their underlying values gets back to the narrative piece. And it's only after we understand that we know what a good care plan should look like. And increasingly, as you mentioned, organizations are coming into supportive stances with regard to VSED, including AMDA, which is the Society for Post-Acute and Long-Term Care Medicine, the American Nurses Association, and others. So that may pave the way for greater acceptance. But from the person's standpoint and the family's standpoint, I think talking with a prospective long-term care facility in advance to understand their position about VSED, if you're thinking that you might want to do that at some point, before you put money on the line, especially in a life care setting where there may be tens of thousands of dollars of deposit money at stake, you don't want to lose all of that. So understanding their position before you sign is important. So just getting back to one other ethical issue, Thaddeus, maybe if you could talk about conscientious objection to participation in VSED and how that might be handled.
Sure. So let's put aside, right, the stuff you were talking about. Maybe even if you're a facility and you have no regulatory concerns, you're sure that you're never going to hear from a surveyor or a regulator about this, you may still be unwilling to participate in VSED, either at the clinician level or at the entity level, right, for personal conscience, religious, or moral reasons. And both state and federal law protect both individuals and facilities, allowing them to assert conscience-based objections, allowing them to not have to do what they otherwise might have a duty to do. So they don't have to participate in healthcare that they find immoral. And generally, the only duty that they do have is to transition the patient's care to another willing provider and transfer the patient's records. And I'll just, I guess, double up on your warning, which is a significant percentage of healthcare in the United States is religiously affiliated. And a lot of that is Catholic affiliated in particular. And generally, the facilities do oppose VSED. So it's important, as you said, to check out the facilities that you might be interested in going to make sure whether or not they have a conscience-based objection. But let's move now, because we want to get to the Q&A. Let's move to the issue of stopping eating and drinking by advance directive, or SED by AD. Everything we've talked about so far for the last 50 minutes, right, has assumed that the individual has decision-making capacity. But there's two situations where they don't. One is the one that you mentioned a little bit, which is the people who start VSED will get delirious and lose capacity at some point during the process, and then are unable to direct their own care. But then there's another population. There's people who are worried about future suffering, not current suffering, but future suffering. They're worried about dying in a prolonged way, most notably dementia. Some consider hastening their death by VSED now to avoid that later suffering, but by doing that, by acting so prematurely, they sacrifice years of what they would consider satisfactory quality life. So rather than acting prematurely, people complete an advance directive today, while they still have capacity, directing stopping eating and drinking in the future when they don't have capacity. And so they would specify, when I get to when these conditions obtain, when I don't recognize my family, when I can't go to the bathroom by myself, or whatever the conditions are, that's when I don't want to be fed anymore. So we call that stopping eating and drinking by advance directive. Sometimes they're called dementia directives, which are advanced care planning tools to help assure that you can avoid living for years with severe dementia. And those typically specify conditions under which oral food and fluids should be withheld. But before we dive into this, stopping eating and drinking by advance directive, we want to stop again now and ask you about your familiarity or your experience with stopping eating and drinking by advance directive. We asked you earlier about VSED. This is now about completing an advance directive, directing stopping eating and drinking in the future. So let me see, are we, so you should see the poll. So have you been involved with honoring an advance directive for SED? And people are starting to respond, right? So either yes, I have been involved as a friend or family member, yes, I've been involved as a clinician, or yes, I've been involved as both a clinician and as a friend or family member, or no, I have not had anything to do with advanced directives for SED.
People are still weighing in.
Right, about 80 people have voted. Maybe we'll just wait. Good, some more people are voting. So we'll post. I guess we'll just want now over 100 people, 120 people. Okay, I guess we can share these now. Interestingly, or overwhelmingly, right, over 83% of you said haven't had anything to do with this. But interestingly, 20 people have had some involvement with honoring in an advance directive for SED. So, by the way, a lot of people have been asking questions so far. So we would love to hear from you. If you could share whether that was successful or whether that was ended up being a good experience or whether that was challenging. Did we share?
So maybe.
Yeah.
Oh, go ahead.
I just want to make sure we shared the visual of the results so people could see that. Oh, we did. Okay, great. Go ahead, David.
Yeah, so we allow enough time for questions at the end. Let's talk a little bit about the ethics of stopping eating and drinking by advance directive. Is it different than VSED?
Yes, it's a lot weaker. And that's primarily because we're not really sure that this is what the patient really wanted, right? The patient before us right now, she lacks capacity. She can't speak for herself. And we're really not sure, and there's a big debate about whether we should honor the instructions that the person completed years in the past while she still had capacity, or we should act in the best interest of the human being that's in the bed before us right now, because they may take us in opposite directions. But that said, there is a spectrum of ethical acceptability. The case for honoring the advance directive is strongest where we're more confident that SED is what the patient wanted. And we have that level of confidence when we have a solid advance directive backed up by a video recording of the person showing that they have capacity, that they understood the choices that they're making, that they describe the reasons for why they're making those choices. The case for SED is a lot weaker when the surrogates show up with and ask for SED when they don't have any specific instructions or directions from the patient herself. And so it's just their guess or estimate that this is what the patient would have wanted, or it's their estimate that this would be in the patient's best interest. And that's where a lot of people think that's not good enough, right? We need to hear this from the patient herself, and we need to have a high level of confidence that she really, truly considered this carefully. In that case, maybe we think it's justifiable to honor it, but not when it's just an agent or surrogate or guardian asking for it on the patient's behalf.
All right. So how about the legal aspects? Where are we on that?
Yeah, not much better. There's enormous variability, right? Advance directives are defined by state statute. And so the statute defines what decisions you can make through or with an advance directive. And some states are very clear, like Nevada, very clear, Vermont, very clear. You may make a decision about SED in an advance directive. Other states, like Wisconsin, say you definitely cannot make a decision about SED in advance directives. And then a lot of other states, it's just not clear. Earlier, when we were talking about VSED, right, I mentioned that dozens of court cases have said VSED is absolutely a patient right. It's, it can and should be honored. We don't have cases like that with respect to advance directives. So we don't have a case that says a clinician may honor an advance directive for SED. So we don't have the same level of guidance or clarity about what the law permits. It is important to note, right, that the incapacitated person undergoing SED is, as you mentioned, is probably going to experience discomfort during the process and may ask, or at least appear to be in want of water. And therefore, the advance directive should specify whether the patient wants food and drink withheld, even if their later incapacitated self appears to want it. And only a few states have what we call Ulysses clauses, where you can, in the advance directive, say, I want you to follow my directions to stop eating and drinking, even if my later demented or incapacitated self says something different. So you can override your later self. And that's another controversial, it's legal in some states that have religious clauses, but ethically controversial and not available in many other states.
Mm-hmm.
So legality, so even if it's legal, and it is legal in some states, legality is necessary, but it's definitely not sufficient to guarantee access. So can you talk about the challenges of having a patient get their advance directive for stopping eating and drinking honored in a long-term care facility?
Well, this is going to be where this conversation is going to play out, I think. And certainly in the United States, if you have a dementing illness, more than likely you're going to receive your care towards the very end of your life in a long-term care facility, unless you have a very robust support network, including family network for your care. So let's talk about kind of the existing practices and what we consider to be best practices today. There is this concept of comfort feeding only that has been considered a best practice for about a decade in the care of people with advanced dementing illness. And the idea is that people are given careful hand feeding using just one bite at a time, one-to-one supervision, sitting up, making sure that the swallowing has happened fully before you give the next bite, that kind of thing. And careful hand feeding is continued as long as the person doesn't appear to be distressed, as evidenced by choking or coughing during feeding or shortly thereafter. And the goal is comfort. The goal is not to maintain normal nutritional status. So philosophically, we're not trying to maintain the physiology, we're trying to maintain the comfort with this comfort feeding only strategy. And when loss of interest or signs of distress begin to emerge, that is the point at which oral feeding is stopped. With this approach, some people will decline progressively and eventually die after a period of weight loss and dehydration. But other people can remain stable even for years with comfort feeding only. And in addition, just because you have a directive that says, I want comfort feeding only, doesn't mean it's going to happen this way. And it's common in long-term care facilities for the staff who are actually giving the feeding to coax or cajole or in some way manipulate a resident to eat. And it's not with ill intent, it's just that is their kind of mindset. And so if there is a directive for comfort feeding only and no advocate to see that this is actually happening this way, chances are your directive is not going to be followed. So advocacy is important in comfort feeding only, as in many other things. And even this strategy of the so-called best practice of comfort feeding only may not actually address the concerns of people who really are mainly interested in not living for a long period of time in a setting of prolonged incapacity and cognitive and functional decline.
It's a telling point, right, that an advance directive is just a piece of paper, and it's helpful, but not all by itself. So maybe it might be helpful just to maybe put a fine point on what exactly are the steps somebody can take to maximize the chances that their advance directive for stopping eating and drinking would get honored, right? So it's worth noting that there are a number of dementia directives available from End of Life Choices New York, End of Life Washington, the Dartmouth directive, maybe 5 to 10 more are out there. Most of them are free. And what they help you to do is be clear about what you want and when you want it, right? So you have to be clear, specify the conditions under which you want to stop eating and drinking. And so that's, you have to have an advance directive, have to make sure it's clear. There are probably going to be doubts, right, about whether you truly understood or you truly meant what you're asking for. So that paper advance directive, it would be helpful to supplement that with a video describing your values and wishes, the reasoning behind your choice, because people feel more comfortable when they can hear it literally hear it from the patient herself.
Yes.
And as you said, an advocate, right? Select a surrogate, select an agent, healthcare agent that you know, that you trust, someone who will advocate for your choice, someone who will honor your choice, even if they personally, subjectively think that your quality of life is satisfactory right now. And then to just recap some of the points we made, if you plan to move into a long-term care facility, before you're admitted, discuss it with the facility administrators to make sure that they are willing and prepared to honor that type of directive. And maybe you may run into the situation where you're already in a facility that maybe isn't prepared. If you have the financial resources and the social resources, perhaps consider discharging from the facility to a private home setting and getting and undergoing stopping eating and drinking with family support, with paid caregivers in that setting instead of in the long-term care setting. So just some take-home checklist to maximize. Should we move? I mean, I guess we're a little bit right after the hour here.
Yes.
David.
Let's give the audience a chance to weigh in with questions.
All right. So I see that there are more 50 questions. So Sarah, we're ready.
Excellent. Thank you both, Thaddeus and David, for an excellent discussion on this important topic. First, thank you to the audience for asking so many incredible questions. I'd like to first focus on the clinical questions around VSED. So Deborah Love asks, for both of you, what are your views about prospective requests for VSED by patients who expect to lose capacity but do not want to hasten death too early? What are your thoughts?
Well, I mean, this was kind of my mother's situation, really, and it's going to become more and more common as people of my generation get older. I think the boomer generation tends to like to have control, and these directives are kind of the first foray into really having control over this process. Having said that, there's a lot of resistance in some quarters in the long-term care community about implementing advanced directives for stopping eating and drinking. So what these directives are designed to do is to provide another way so that you don't have to give up those potentially years of satisfactory quality of life by preemptively stopping eating and drinking. So these directives will be the way forward. It's a question of how accepted they will be and how the ethics of stopping eating and drinking by advanced directives will be managed going forward. Thaddeus, other thoughts?
Yeah, I think what I hope we tried to paint was that VSED is very well accepted, right, in professional medical communities and in the law and in ethics, but advanced VSED or SED by AD, not so much. Or at least if it's not accepted, it's just super unclear. People are just uncertain. But there's an amazing amount of interest in this, right? If you go to a library or a town hall meeting on MAID, the most common question you'll get from people who come to a talk about MAID and whether we should legalize MAID in Massachusetts or MAID in Maryland is, what about dementia? And the answer always is, ain't going to help you at all, because you have to have capacity at the time. And with VSED, you have to have capacity at the time. So the interest in making decisions in advance is very, very high. And I think one thing that Jason is going to talk about after we conclude this Q&A is there may be some need for some advocacy to clarify the state of the law and the state of professional ethics with respect to advance requests for stopping eating and drinking, to make things clearer and to eliminate some of that uncertainty.
Thank you both. To follow up on this thread of clinical aspects, Carol Montgomery Taylor asks, many Catholic hospices disapprove, in her opinion, of VSED because they feel that they can mediate pain and ease end-of-life issues without VSED. What are your thoughts on this? Thaddeus, would you like to go first?
Well, I was hoping, since these are clinical questions, David was going to go first.
All right, well, happy to. That implies that we know best for you, and I guess I just have a problem with that assumption. The only way that we know best is by having a conversation about your narrative and what you care about, what values guide your decision making. So that's where I think all these conversations have to start. Now, the organization doesn't have to do something that it feels is against its code of ethics institutionally, but their obligation then is to be very upfront about that. And early on to discuss, well, if you want something different than what we can provide, then we'll arrange to transfer you if possible.
I think, right, one response is in the overwhelming majority of cases, Carol's absolutely right. Hospice and palliative medicine have enormous toolbox, both from a physical symptom standpoint and from a emotional and psychological perspective symptom standpoint. So it's only for a tiny, tiny subset of patients where their symptoms, both physical and existential, are refractory to all of those tools. That's who we're talking about, right? So that's why MAID, in all the 10 states, less than 0.5% of deaths are from MAID because they don't need it. Palliative care, hospice is perfectly sufficient to address all the suffering that they have. So the same answer with VSED. It's only going to be for the tiny subset where they tried and they deployed all of the powerful tools of hospice and palliative care, and the patient is still suffering. That's for whom VSED is appropriate.
Excellent. Thank you both. Before we continue with further questions, I'd like to mention the second continuing education code, which is HASTEN, H-A-S-T-E-N, all caps, and we'll put it in the chat as well. So just keep a note of that if you are seeking continuing education credit. All right, following up with further questions. So this question is from Karen Lieberman. She asks, is there a risk that assisting VSED undermines trust in hospice or long-term care facilities where those institutions are invested in a patient's well-being?
Tackle that, or?
David, please.
That's a concern. I mean, I think I think that hospice is probably better than other settings because hospice is you're already on hospice because you're accepting that your death is relatively imminent, right? Otherwise, you wouldn't have been eligible for hospice. But even in hospice, I think there's a concern that we don't want to actively hasten or help you participate in hastening your death. So, but again, if you're concerned about that, then you don't need to participate. So as I think David mentioned, some hospices are very accepting of VSED and other hospices are not. So I think that this is just one of those areas where your professional and personal values allow you to opt in or opt out as you see fit.
I would be especially concerned in working with people who have a low underlying level of trust in the healthcare system, and especially those who are marginalized or disadvantaged, who may wonder, so do you offer hospice to everyone? Why are you offering hospice to me? Why are you offering hasten death to me? Are you just trying to get rid of me? Who are you doing this for? So those kinds of questions, acknowledging upfront, if you discern a narrative of mistrust in the healthcare system, to acknowledge that openly and to say something like, I sense that it's hard for you to trust the healthcare system based on your experiences. Can we talk a little bit about that? That comes before this conversation.
Actually, one last point. This actually highlights a really big tension in ethics, which is, on the one hand, and this debate is not yet settled, on the one hand, the doctrine of informed consent, both in ethics and in law, would direct that the clinician should make the patient aware of all the options that a reasonably prudent patient would want to know about. So if you're terminally ill, maybe you'd like to know that VSED was an option. You don't need to take that option, but you just want to know what your options are, right? And so that's just regular informed consent rules. On the other hand, as David mentioned, by telling the patient about certain options, the patient might perceive that as that the clinician is pushing or nudging them toward that option, as opposed to empowering the patient. They feel that the patient may feel they're being pushed by the clinician. And it's not quite clear how you reconcile those two competing goals.
Thank you. So somewhat of a follow-up to that you just mentioned, Thaddeus, is a question from Jean Kerwin. And she asks, is VSED acceptable for anyone who is disabled physically, such as someone who's quadriplegic and not depressed? They have capacity, but they want to plan ahead. What would you suggest?
So this is very, so generally, as we said, I think there's a spectrum of acceptability, right? If the patient is terminally ill and they have a 6-month prognosis, people think, well, the VSED is perfectly acceptable in that situation. Once you don't even have a terminal illness or even a serious illness, but just long-standing disability, I think that a lot of clinicians and a lot of ethicists are going to get off the bus and say, we're not as comfortable with VSED in that situation. So I think it's just worth noting. I think it's thought to be less acceptable. But I think we did say that one of the virtues of VSED is that there are no eligibility conditions like there are with MAID. And therefore, anybody can decide that the life that I'm living, or the life that I expect to be living tomorrow, is unacceptable. I find this to be intolerable. I don't like living the life that I'm living. And VSED is an option in those situations, because legally, at least, there's no eligibility conditions. But I think a lot of people are going to want to make very, as David said, a very careful exploration of why the patient is asking for that, and to explore other ways to alleviate the concerns that are driving that request other than VSED.
Yes, I agree with that completely. So it starts with unpacking the narrative, understanding the origins of suffering, and really vigorously addressing those underlying origins and causes as much as possible. And then, and only then, is it, in my opinion, a good time to talk about the specific interventions and alternatives for people who still say, thank you very much, I appreciate everything you've done, but I still want hasten death. Then you can talk about the alternatives, risks and benefits in that setting.
Great, thank you. So a question around whether continuous palliative sedation is ever justified to alleviate symptoms or discomfort, for example, the discomfort of thirst specifically caused by VSED, or is that a bridge too far? And is there a proper clinical and legal response to this? This is a combination of two questions posed by Karen Lieberman and David Hoffman. Your thoughts?
I think, well, I'll see what David disagrees with me. So I think we painted that VSED doesn't have exactly the strongest amount of literature on it and guidance on it. Palliative sedation has less. So whatever sort of ambiguity and uncertainty we have with VSED, it's exponentially greater with respect to palliative sedation. And so I think it's especially hard to answer that question. I think the polls show that palliative sedation to unconsciousness, at least, should be limited to refractory physical symptoms. And many clinicians are not comfortable with deploying palliative sedation to unconsciousness for existential suffering. So I guess there's going to be a big gap between what we might think is ethically justified versus what is actually practically accessible in the real world on this one.
So it'll start with having that conversation around approach to symptom management up front before VSED begins. And palliative sedation is among the tools of last resort when other measures are insufficient to control symptoms at the end of life. So if I've got a person with agitated delirium and we've had this conversation, which is, in my world, this is checklist based. So we run through the checklist and agree that palliative sedation might be indicated if necessary. If I have to sedate the person to unconsciousness to control the symptom, we've already agreed that this is the approach to take. So I would have no problem in that circumstance knowing that it aligns with the person's underlying values at the end of life. And typically in this situation, we would also have a conversation around nutrition and hydration. And for the person who's VSEDing, so to speak, we're not going to have that. We're not going to be putting in a feeding tube to provide food and fluids. And so we're not going to cause the person to die by dehydration because we're sedating. So I don't see a problem in that sort of gray area between palliative sedation to unconsciousness and euthanasia in this situation. Does that make sense?
Yeah. It is worth noting, right, that when you have, when it's advanced VSED or SED by AD, even if you do the mouth care, the person may be experiencing some of the symptoms of thirst and dehydration. But unlike the capacitated person, they don't understand, right? They don't have the willpower to think, well, I'm doing this. I understand I chose to do this and I want to do this to avoid some conditions. They don't understand why they're experiencing these symptoms. So the case for palliative sedation to unconsciousness, I think, is especially strong when it's an incapacitated person, in which case they're not going to, if they're unconscious now they definitely can't take food and fluid by mouth, and presumably typically when you elect palliative sedation or unconsciousness, you also elect to forego artificial nutrition and hydration. So you're still going to die from dehydration, but it's really dying from the lack of artificial nutrition and hydration because that was the only available means for a completely unconscious patient. But it's definitely not the accepted pathway that every advanced VSED case automatically becomes a palliative sedation case. There's an argument that maybe that should be strongly considered, but it's definitely not the standard of care.
And I do think we want to avoid the situation where any level of discomfort is going to lead to palliative sedation to unconsciousness. I think that is a bridge too far. It's only as a last resort. You know, we are now looking at agitated delirium, and very diligent mouth care is not solving the problem. Other attention to comfort is not solving the problem. What do we have left? That's the situation we're talking about here.
I see. Thank you. So pivoting to kind of a home care situation, Donna Abbott asks, if you VSED as an individual at home and your caregiver is okay with it, but you never specifically put this in your advance directive, can you proceed without legal consequences for your caregiver?
Yeah, I mean, the answer is yes, but the best practice would be for the person to have completed an advance directive, because at some point they are not able to vouch for the fact that they picked this, that they wanted this. So if APS, Adult Protective Services, shows up because a neighbor called them, it's going to look to APS like you are dehydrating somebody who's vulnerable and cannot protect themselves, right? That's what it's going to look like. And you're going to want to say, no, they wanted this. They asked me to help them do this, but where's your proof, right? So I think the documentation, the careful documentation by the patient herself is very important. Yes, maybe nobody will ever call APS, in which case it's never going to be a problem, but you should cross as many T's and dot as many I's as you can to mitigate those risks.
Well said. Nothing to add.
Great, thank you. So this question is from John Kelly, and he asks specifically to you, David, what about a situation where a mother, I presume an elderly mother, John, doesn't want to be a burden, say financially, and the adult children agree that she is a burden, and she would like to proceed right away. What are the ethical concerns in this scenario? Your thoughts?
I would be concerned about coercion, either explicit or implied in this situation. This might be a situation where getting a second opinion to evaluate the situation would be appropriate. And it sounds like this is a clinician-initiated process. In this case, where at least on the surface, the person and the family appear to agree this should happen this way. As a clinician, I would have some concerns about that. And maybe I will call my friendly neighborhood ethicist and say, I'm feeling queasy about this. What do you think? What other kinds of things do we need to consider? And is this something that I can even participate in as a clinician? I think it's probably more common than we may realize or acknowledge that financial burden may be a consideration, especially for people who are not at the top of the socioeconomic ladder. For people who don't have resources, if you've got to spend down your resources of the family, what we know is that a third of families spend most or all of their financial resources in the final period of life when one or the other of a couple is in the dying process. That's huge. And what does that leave for the person who's left? So if we're not allowing for that part of the conversation, then we're probably missing something important here. So that's the flip side. So I think it's okay to talk about finances as a concern, but maybe just making sure about the coercion part of this and seeing what else can we do to support this person and this family. Or have we really thought through all of the resources that we could make available? So, Thaddeus, other thoughts?
I agree with everything you said. I mean, I think that wanting to save your resources is a legitimate reason to make healthcare decisions. But we have to vet it. We do have to vet it very carefully, because it looks the person that's going to get those resources obviously may have a conflict of interest. And to John's point, if this is what he's suggesting, we probably could do a better job at vetting that. So at least, for example, in the MAID discussions, there are, maybe they could be stronger, but there are some rules about that you have to meet with the patient by herself outside the presence of the family to make sure that there isn't some coercion or duress, where they would feel free to share, my kids are making me do this.
Very important.
So we should have some policies and procedures to vet out any type of coercion or duress.
Thank you both. So it sounds like careful assessment and consideration is crucial in this situation. So this dovetails nicely with our next question from Lisa Heikoff from Kaiser Permanente. She asks, how would one determine that the threshold set in advance directive has been reached? And how would one deal with disagreement among family members, assuming that the threshold or the considerations put into the advance directive are somewhat vague or unclear? Your thoughts?
So I know Lisa knows this, right? But this is not unique, right? The challenge that she's describing is not unique at all to SED, right? We have problems knowing when regular, quote unquote, regular advance directives people write things like no heroic measures, or when I don't have a significant chance of recovery. When is that condition met, right? So I would say that all advance directives have, or most of them have, an ambiguity problem that you don't know when the triggering conditions have been satisfied. And there will be, in some cases, conflict because some family members will say the conditions have been met and others will say they haven't yet been met. I think careful drafting can mitigate those concerns. So you can specify ADL, activities of daily living, when I can't do A, B, C, and D. That's the time. And there are some great tools out there, planning tools that help you specify those conditions in a way that's measurable. So you can say, these are the measures, and you can even specify who is it that's going to measure it, right? You could say, it's my surrogate, my healthcare agent that I've appointed. They get to decide when the condition's satisfied. So I think you can eliminate a lot of that uncertainty with careful drafting. I don't think that advanced directives are very as carefully drafted as they could be. These ones probably are going to push people to reach that level of clarity.
I agree. And in fact, we're seeing more and more specificity in the guidance that goes along with the advanced directive to help people really gain clarity and avoid this uncertainty in when to trigger the directive. So it's only going to get more specific over time, I think.
I mean, I'll just mention, not to plug any specific tool, but I'm actually fairly impressed. There's a Stanley Terman has a tool which he calls it My Way cards, and there's it used to be a whole deck of cards, with different conditions, and you could go through and say this condition is acceptable, this condition is not acceptable. So you sort of sort the cards. Now it's digitally available too, but the idea is it really forces you to specify with a high level of precision and detail the conditions that you find acceptable, the conditions that you don't find acceptable. And you could say something like, when all 12 of these conditions are satisfied, that's when to do it. Or you could say, when 9 out of the 12 conditions are satisfied, that's when to implement the SED plan. So there are tools out there, his is not the only one, but there are tools out there that help sort of facilitate your deliberation process, and that would then also help you record those preferences in a way that people could interpret in an implementable way.
Thank you both. So the next question comes from Stephanie Elkins, and she's curious about the suggestions and response that you both would advise to provide for the family of a person opting for VSED. So for the family who has made preparations, they've had these conversations and the individual has planned, whether specifically or not specifically in their advance directive for VSED. How do you respond to family concerns that they are concerned with, quote unquote, starving their family member and loved one to death and dehydrating them? What are the words of medical support, comfort, and other alternatives so that the family can feel that they are present and engaged with their loved one?
Well, to start with, having a full conversation and exploration around those concerns to understand the perception of starvation or dying of thirst. These are emotionally loaded terms that people may bring to the conversation, and asking questions about what do you worry might happen? What are your greatest fears? Just opens the door for people to talk about that and to really address the emotions first before talking about here's the plan. So it has to happen in that order. So first you unpack, tell me about what you're worried about, and then you develop a plan once there's been a fuller exploration. So this is kind of the palliative care approach.
Two things. One is, this is not unique, right? The concern that we are complicit in something immoral here is not unique to VSED, right? So people are concerned that if they don't, if they accept a recommendation in the hospital to move to comfort measures only instead of continuing to deploy ICU level care, that then they feel guilty that they are, again, causing the death of the patient or hastening the death of the patient. So the concern of complicity is, I think, not at all unique to VSED. And it's worth noting that all the polls, right, from the Pew Foundation to the California Healthcare Foundation, show that at best, only 15% of Americans are vitalists, right? Most of us are okay with letting go in the face of illness, and I think it's worth emphasizing that this is widely accepted as a legitimate option. So, and I don't think that the word starving is very loaded. I don't even think it's clinically accurate. I mean, you are dehydrating the patient, but starving, I think, is a term that, again, has a level of connotation that's not really accurate here, because this is under hospice or palliative supervision. So I think that term is just too loaded to use, and I think it's worth pointing out that it's not even technically accurate.
There may be situations as well where the family remains conflicted, and sometimes it's appropriate for the team, the healthcare team, to step forward and own a little bit of this, to say, given everything we understand about this person and what she has told us is important, we recommend the following approach. And so to kind of take the family off the hook a little bit in a shared decision-making process can be a way to relieve the underlying distress and sense of being responsible or complicit.
Thank you both. Now I'd like to pivot to the legal considerations and questions that our audience has surrounding this. So William Polito asks, has any court in New York determined that VSED is allowed or not allowed under state law? For example, the Family Healthcare Decision Act or law, or the Penal Code prohibiting assisted suicide. What are your thoughts?
Well, so multiple courts, 2 or 3 courts in New York have approved a patient's decision to VSED. So these are cases that were a conflict between the patient and a facility, and the facility either took it to court to get a declaratory judgment, or the patient took it to court to force the facility to honor the VSED plan. The patient won in all those cases. Now that said, they were all trial level cases, so they don't have precedential authority. So they're all just local New York Supreme, what New York calls Supreme Courts, the trial level court. But that is precedent. those cases predate the Family Health Care Decisions Act. And I guess it's worth noting that that act specifically is not going to be useful for VSED. First of all, that would only be useful for advanced VSED, right? Because that's an act that allows family members to speak on behalf of incapacitated family members. And that's not a decision. VSED is not a decision that a surrogate in New York could make on behalf of an incapacitated family member. There's some work in New York to amend that, to amend the statutory law in New York. But the bottom line is, let me just be real clear, contemporaneous VSED by a capacitated patient, that's been approved by New York courts. Advance requests for stopping eating and drinking have not been approved by New York courts, and probably the statutory law in New York that governs that not super friendly right now toward that.
Great, thank you. So a separate legal question comes from Mary Ganapol relating to the law in Nevada, or Senate Bill 121 from October 2019, last year, that allows VSED explicitly worded on an advance directive. And Mary notes that the Nevada SB 121 also has reciprocity in other states, such as California and Minnesota. And she's wondering, will this become a new movement, reciprocity between advanced dementia directives between different states? And what do you think that will look like? Thoughts?
So that's a great question. So just to recap what Mary's saying is that Nevada, many states have an official form, right, that the state itself publishes. And in most states, you don't have to use the state form. You could use one from a whole bunch of nonprofit organizations. But the official Nevada state form specifically allows a choice about refusing food and water. And that may be unique to Nevada. So that's great for people in Nevada, perhaps. But I think what Mary's question is, what about people in other states? Is there a way to use the Nevada statute even though you're not in Nevada? And every state has some kind of reciprocity provision, meaning if I showed up right now in New York with a Minnesota advance directive, New York clinicians would probably honor it. If a New Yorker showed up here in Minnesota, Minnesota clinicians would probably honor it. So we have these reciprocity provisions. So what Mary's saying is, why can't anybody anywhere, whether it's Florida or New York, just complete a Nevada advance directive and then have that used where they are? Technically, from a purely technical perspective, I think in many states that would be a legal right. The problem is, as David emphasized, there's a big gap between technical legality and whether in an actual long-term care facility that advance directive is actually getting on. I think David literally said, if you don't have an advocate, there's a good chance your advance directive won't be honored. And so the gap between legality and implementation is unfortunately kind of wide. And when you're saying that, and this is pretty technical, and I think people are going to be a little bit unsure about relying upon this. Maybe if you took it to court and you have a judge who's a legal specialist, you could convince the judge. But I think you're going to have a hard time convincing a long-term care administrator that they need to follow in Washington State or New York State, that they need to honor this Nevada directive.
Thank you. So Gary Wiederspan from Final Exit Network writes that Final Exit Network offers a free supplemental advance directive for dementia that includes free legal enforcement if required. So his question, would the threat of legal action increase the likelihood of patients' choice of VSED being honored?
Would the threat? Depends on the it depends on the threat, I suppose. Right? I mean, I think, first of all, it's great, right? Like the fact that Final Exit Network has a special document, just like end-of-life choices in New York, end-of-life Washington, Dartmouth, and a bunch of others. That's great. It shows that there's a lot of innovation here. And I do think it's commendable that FEN, if somebody uses one of their directives and then has a problem getting it honored, that FEN will, hire local counsel or whatever their plan is to help get that directive enforced. And if the question is how many steps do you need to go down? Is it enough that the lawyer calls the facility and says, you better honor it? And then the mere fact that a lawyer called, is that enough? Do they actually have to file a complaint? So I think it's unclear. Depends on the level of risk averseness of the facility. But anyway, I think it's great to hear from Gary that FEN is willing to do that, because as of right now, as we mentioned, there is not a court in the country that actually said, yes, you long-term care facility, you must honor this, or even you may honor this, right? We have no guidance right now on the answers to these questions. So if FEN can create some guidance, create some jurisprudence in this area, that would be wonderful.
Even short of jurisprudence, it will capture the attention of a long-term care facility to hear from an attorney and bring attention to what are we actually doing here and what is the right thing to do. So if nothing else, calling attention to the specific question. There are many other concerns that administrators and clinicians have in these facilities. So it focuses their attention is what I'm saying.
Great. I have one more question for you. Unfortunately, we are running out of time and we'll go right up until the end of the hour today. And thank you all for your incredible questions. So this last question, it comes from Timothy Quill, an expert on palliative care. But he's curious on your thoughts on how do you advise responding to an advance directive for VSED at a certain stage of dementia, when the person who has reached that stage appears to be enjoying eating and drinking and can no longer consent to the actual initiation of SED? What are your thoughts?
Well, it sort of gets to the then self versus now self question. I kind of like Paul Menzel's conception of, how much is this person engaged in the act of eating and drinking? Is this a person who seems to be enjoying their life as she is today and enthusiastic about taking in food and fluids? Or is this a person who is very apathetic and really only responds to a certain amount of coaxing and cajoling and reflex activity to get the person to eat and drink? Now, there may be a difference there, and perhaps we should take a nuanced approach in deciding, should the directive hold sway in making this decision for the person, or should we honor the person as she is now to say there's a lot of enjoyment and satisfaction here as we see it now? So I think that's one of the big open controversies that remains still active and to be resolved. Thaddeus?
And I'll be brief. First of all, I want to acknowledge that this question demonstrates what a super thoughtful clinician and ethicist Tim Quill is, right? Somebody who absolutely defends medical aid in dying, took a case to the US Supreme Court on that question, yet not so comfortable with every patient right that's exercised to hasten death. I think, though I disagree with Tim on this point, I think that we as a society accept what we call Ulysses clauses. They're not so common in healthcare, but they are really common in mental health care, right? So somebody in a time of lucidity will say, yes, I may later in my, when I'm having an episode, refuse these meds. But right now, I'm telling you, give me the meds, even if I later refuse them in a psychotic state. So super common, and we think that people are allowed, when they have capacity, to make decisions that constrain or limit their future incapacitated self. So the mere fact that the patient appears to enjoy their current life, that's an inference that you're making. The author of that life said, I don't want to live like that. And I think we should listen to the person when they speak with capacity, and not listen to the person when they, quote unquote, speak without capacity.
Thank you both so much. This has been an incredible discussion and conversation on voluntarily stopping eating and drinking. And now I'd like to turn over the presentation to the president of the Completed Life Initiative, our own Jason Smith, for concluding remarks. Jason?
Thank you, Sarah, and thank you all for joining us in the midst of this historic moment in time. The COVID-19 pandemic continues to rage, prompting concerns about mortality and, more importantly, the quality of end of life. Throughout these 6 weeks of the Completed Life Conference, you have been privy to the foremost scholarship and clinical expertise of individuals who go above and beyond in their daily practice as bioethicists and healthcare providers. These individuals are doing their part to change the world. The mission of the Completed Life Initiative is to provide a broad platform for safe and free public discussion and to engage with individuals from all layers of our society, including lay people and professionals from the medical, academic, theological, and legal fields, while advocating for the core concept that people ought to be able to avoid suffering and, with appropriate safeguards in place, end their lives with autonomy and dignity when they reasonably deem their lives to be completed. The ability and freedom of people to deem their lives completed is also known as the right of self-determination, which should be recognized as a basic and fundamental human right, both in the United States and around the world. Advocating for the right to self-determination holds personal significance for me. The prospect of someone with a terminal illness who is suffering beyond measure is deeply harrowing, and I have unfortunately witnessed it firsthand with my dear friend Rebecca. Throughout Rebecca's later years, and especially at the end of her life, she suffered from multiple sclerosis and significantly deteriorating osteoporosis. Her condition was so bad that her spine and rib cage began to collapse forward, placing tremendous debilitating pressure on her lungs, internal organs, and pelvis. Rebecca's pain was absolutely unbearable, and its intensity was only amplified by her clear and lucid mind. Rebecca would call me every day, agonizing about how the pain management methods available to her were entirely ineffective, and how she dreaded waking up each day in so much pain. She couldn't stand to be so moribund. And finally, she couldn't take it anymore, and with no real option readily available to her that would ensure that she could die with dignity, she took her own life in her own hands and suffocated herself with a plastic bag. A most ungracious and undignified death that no one should ever have to suffer. If Rebecca had been allowed to die with dignity, she would have been able to conclude her life while she still enjoyed it, while her suffering was much more manageable, and when she could still enjoy the company of her friends and family. Yet because Rebecca was not classified as a terminal patient by her medical care team, she did not qualify for medical aid in dying, and being forced to endure so much suffering ultimately took matters into her own hands. At the end of her life, Rebecca was lucid and able to make an informed decision regarding her condition as a patient with an irreversible medical condition that could result in her death. This conference was the first step toward achieving our mission. Over the past 6 weeks, you have engaged with an ensemble of highly distinguished speakers that collectively shone a spotlight on the completed life. We discussed questions like the following. What is the role of religion in holding end-of-life conversations and making end-of-life treatment decisions? In such a death-denying society, how do we guide patients very early on to explore their thoughts about end-of-life care and have these conversations with their healthcare providers before they reach a crisis scenario? And legislation to seek medical aid in dying is currently only available in 8 states in the United States. Who are the opponents of this legislation? How can we make options more widely and legally available for patients? And is hastening death inconsistent with the hospice philosophy or practice? And have there been any legal challenges in the United States to hand feeding, where family want to ensure that patients' wishes are honored, where an advance directive is clear that the patient did not want to be hand-fed? These are intriguing questions, and we hope that you have found the conference illuminating and thought-provoking, yet still leaving you wanting more. And to that end, we ask that you continue to engage with us as we move forward with our mission. I extend a cordial invitation for you to join us in this important work going forward. We need your input, your ideas, your energy, your engagement, and your voice in order to make our vision a reality. Now that you have reached the conclusion of the inaugural Completed Life Conference, I invite you to take action today. Your continued participation and support for the Completed Life Initiative enables us to continue our grassroots momentum to create an additional national platform for patients' rights advocacy, promoting educational outreach on mortality and personal dignity, and creating positive change within advanced care planning nationwide and worldwide. You can start by spreading the word about our mission to your networks and communities via word of mouth and social media. In the coming months, the Completed Life Initiative will host select town hall meetings, film screenings, and book discussion groups that will delve deeper into the completed life and focus in more detail on some of the topics that have been discussed during this year's conference. We will also sponsor semester-long internships and year-long internships and fellowships. And we will also be organizing volunteer groups comprised of individuals interested in using legislative advocacy and public impact litigation to further our mission. If you are a lawyer or current law student, you can sign up for our legislative discussion group, which is dedicated to advocating for the protection of patients' rights at the end of life, and to help clarify the law nationwide in the United States. This discussion group opportunity can also be turned into an externship for a second or third year law student who is passionate about healthcare law. You can sign up for the legislative discussion group via the link on the slide. Your membership within the Completed Life community includes a subscription to our newsletter, where you will be privy to all future announcements related to upcoming Completed Life events and opportunities, such as future discussion groups, film screenings, and book club discussions. You can sign up for our newsletter by going to our website at completedlife.org. Last, but certainly not least, we will soon be planning next year's Completed Life Conference, which we plan to hold during the late summer and early fall of 2021. Your continued participation and support for the Completed Life Initiative enables us to continue our grassroots momentum to create an additional national platform for patient rights advocacy, promoting educational outreach on mortality and personal dignity, and creating personal positive change within advanced care planning nationwide. This is just the beginning, and we look forward to working with you as we move forward in this important work. Thank you, Sarah. Thank you, Thaddeus and David. It's been an honor working with you these past months and year, really, and we look forward to the many wonderful things that are yet to come. Thank you.
Thank you so much, Jason, for an incredible concluding presentation. I just want to give all of you a round of applause. This concludes the inaugural Completed Life Conference. This is the 6th and final session. So just a round of applause to David, Thaddeus, and Jason. And also not pictured here today, our founder, Faye Summerfield, who had the courage to ask the question, what is the completed life? So thank you, Faith. Thank you, Jason. Thank you to everyone on our advisory board for making this dream a reality, and a reality for all of you to engage with us. It's been an incredible journey. We've been honored and delighted to have you along for the ride. And as Jason said, this is just the beginning. So a survey popped up on your screen when we all went to gallery view. So please take a moment to fill out the survey and give us your honest feedback about what you enjoyed in this conference, what you would like to see us cover next time, and any other feedback and observations you would like to include. So thank you again so much. Please go to our website and sign up for the newsletter to stay informed. As part of the Completed Life community, you will automatically receive our newsletter, but please continue to spread the word. Tell your friends, your family, your networks, and communities. And for those of you interested in legal advocacy, please sign up for the discussion board with the link on the slide. So thank you so much. #CompletedLife, and have a wonderful rest of your day.